said, you have to be careful as to when this is appropriate. Sometimes it is, it isn't. And if you look at the PNS cancers that we treat, then maybe not more than 15%, 20%. So why, when, and how? Has to be many surgical options for paranasal sinus cancers, many. And these are the two major options. So total maxillectomy is a standard operation that's been around for a while. And then, of course, craniofacial resection came in some 30-35 years ago and demonstrated to us that control rates were better, 20% better, 30% better for lesions getting onto the ethmoids and beyond. But since then, much has improved, much has improved. So we have radiology, we have endoscopy, and we know exactly what to expect when we go in. It's not like the olden days. We know exactly what to expect. And so we have moved on to doing partial maxillectomy at times, and we have moved on to doing endoscopic excision at times. And even the craniofacial resection has been modified a bit. The fact, however, remains that even conventional surgery for PNS cancers has limitations. And this is a very well-known international collaborative study which looked at some 10-12 leading institutions all over the world. And even in these leading institutions, we find that if you go on for a craniofacial resection, then there is significant mortality, significant complications, and a significant incidence of positive margins. So even oncologically, it is sometimes not adequate. And that continues to be the case not only for this situation, but also for total maxillectomy. Because oftentimes the disease can be a little bit beyond what the operation can cover. So what is the place for endoscopy? I mean, when the conventional operation itself is often inadequate. So what is the place for endoscopy? So as I said, with current radiology and current endoscopy, it is sometimes possible to select patients which can give you an equivalent oncoresection, And if you have a patient where you believe that the endoscope will give you equivalent oncoresection, then this is something that you can do. There are two ways you do it. You can do it through the nose, and you can do it through a dentures. So dentures means that you sort of take away the anterior wall of the maxilla and do a sublabial incision, and that gives you a little bit more space to go in. Endoscopic excision does not stand by the usual principles of oncosurgery. So what are the usual principles of oncosurgery? These were put forth almost 100 years ago by Halsted, who was famous for the breast operation. And the basic principle of oncosurgery has been that first you have to ligate the vessels around the tumor, both the veins and the arteries. That is why when we do a neck dissection, we're initially told that you should always ligate the IJV first. The idea is that there should not be tumor spill into the vascular system and beyond because of manipulation. So first you have to ligate the vessels around the tumor in conventional operations. Then you have to approach the tumor from the periphery. You're not supposed to look at, touch it, just come from the periphery, and of course get adequate mucosal and deep margins. Fairly straightforward. You can't quite do that with endoscopy, but there are certain similar principles for endoscopy. You could see a modification of these principles. So when you do endoscopy, again, you like to first go to the vessels and seal the vessels. Arteries and veins, you get a vascular tumor, easier to do. When you do tumor resection, you have to handle tumor, but you minimize tumor spill by using instruments so that there is no tumor scatter. And again, in terms of margins, you don't do an en bloc resection, but you have to sample all peripheral margins. And as for the depth, you have to go one layer beyond the involved layer. Even for conventional maxillectomy, that's the usual concept. So you have to go one layer beyond. So how do you do it? Let's examine how we do it. So these are the principles. You can see them up there. So first, of course, is case selection. I would emphasize that very strongly. Case selection is, in terms of anatomical localization, that is obvious. You know the limits as to where the endoscope can take you and where you can't. But it's also about tumor histology. You don't really want very high-grade tumors where you need large margins. You don't want very vascular tumors because they'll bleed and you'll have difficulty. And even in terms of the surgical resection goal, sometimes your goal is more of a palliative resection in a recurrent tumor. This can be a good minimally invasive way of doing it. Sometimes your goal is a curative en bloc resection, and then you have to be a little bit more careful with regard to anatomical limits, as you should be. So anatomy is key, as always, for all surgery. Anatomy is key. The limits have been listed out in a position paper which came out some 8-10 years ago, fairly commonsensical. I mean, if a tumor is involving the skin, it obviously can't be done by an endoscope. If a tumor needs a full maxillectomy, it can't be done endoscopically. But if it only needs excision of the medial wall of the maxilla and the nose, then yes. So fairly commonsensical, but as I said, the first thing you have to consider is case selection and whether you can do this operation as well endoscopically as not. Beyond that, as I said, first thing is, the first principle was vascular control, as you can see at the top of the slide. So you can do vascular control by ligating the vessels. What I often tend to do is to give blocks for the anterior ethmoidal and insinuate a fair amount of local anesthetic, 2 cc, 3 cc around the anterior ethmoidal foramen and the sphenopalatine foramen. That's the anterior ethmoidal foramen being infiltrated, that's the sphenopalatine foramen being infiltrated through a greater palatine nerve block. And that gives you mechanical pressure around the vessels to give you transient ischemia while you do the operation. Then you go in and you find the vessels and seal them, and you can clip the sphenopalatine artery and the anterior maxillary artery or bipolar them. And if necessary, you can go through the maxillary sinus, take away the posterior wall of the maxillary sinus, and seal the same vessel a bit more laterally. So again, vascular control, similar to what you did for a Hallstadian operation, so very similar, but you can sort of keep the same principles for endoscopy. So this is the posterior wall of maxilla taken away and the vessel being clipped in the posterior wall of maxilla. And sometimes you can sort of preempt your reconstruction also if you need to take a Haddad flap or a nasoseptal flap. Then when you take the flap, that also isolates the tumor from the vessel, because now the vessel is left only on the flap. So you can take a Haddad flap and prepare it. So as I said, first principle is vascular control. You devascularize the tumor, and that is the first thing to do. Next, you, as I said, minimize tumor spill. So you use equipment like a microdebrider, wherein you suck the tumor into the instrument rather than otherwise take it. You take a few biopsies, and that is the only reason why you take these kinds of forceps. Otherwise, you generally use only microdebriders. For margins, as I said, you have to go one layer beyond in the depth. So this is an ethmoidal tumor. You have to go beyond. You're removing the orbital periosteum also to expose the fat, one layer beyond. Superiorly, if the tumor is abutting the cribriform plate, you'll have to go a little bit more beyond to maybe expose the cribriform plate and the dura, and if it surgically creates a CSF leak, it creates a CSF leak. Because as I said, you have to do the operation which is oncologically required, and nowadays technology allows you to do it endoscopically. As I said, you have to take margins from all peripheries, and this is a usual histology. So tumor from the frontal sinus shows so-and-so, tumor anteriorly, posteriorly. So you send specimens from every edge and get margins from every edge and make sure they're clear. And then, of course, whatever you take out, you have to put back. So in this situation, you would have to do a CSF repair. And that is now, again, something that has been well developed from the endoscopic route for a couple of decades and is easily achieved. And usually we use fat and a fascia and the flap, the nasoseptal flap. So 3 Fs, the fat, the fascia, and the flap. And so that was fat, then there was a overlay graft, and then the nasoseptal flap. And as I said, this is what you do, this is what can be done. You have to be careful when you can do it, when it's appropriate. You could do it for smaller tumors, you could do it for larger tumors. This is another patient who obviously seems a little bit more challenging. It's an olfactory groove meningioma. But again, you look at case selection and examine. It is anatomically accessible, it's not too lateral, and it's not too anterior. That's where you run into problems. If it's too lateral, then certainly it's not accessible, and if it's too anterior, it's difficult to access. You can get there. Nowadays, endoscopes can take you anywhere with angioscopes, but the point is, can you get there into an oncological resection? You have to be careful. So you can do these kinds of tumors. Meningiomas are not very high-grade malignant tumors, and you can get to the blood vessels, which are primarily the anterior ethmoidal vessel. And exactly the same principles. You do the same things. You seal the anterior ethmoidal. You can do the the sphenopalatine artery. You can take a Haddad flap, and I will just take you quickly a little bit forward. There's not so much time. And you can do the resection, and once you have done the resection, you can again seal. So nowadays there are ways of sealing wherein even large defects can be sealed. So there's a fairly large dural defect. Meningioma arises from the meninges, and you can still put in a large graft and fat and flap and still get a good seal. So as I said, technology allows us to do a lot of things. What you have to be careful is the oncologically appropriate to do that? So this is a seal after doing a dural resection, transcriptiform excision. Technically possible, and we use some aids. We use image guidance. We could use intraop Doppler. We don't have that. It would be nice to have, because then you have more positive identification of where the major vessels are. But image guidance is useful because when you're going through tumor, when you're going up through tumor, it's nice to know how much further you can go or should go, or how much further tumor is. And image guidance is basically a roadmap or Google Maps for the particular patient, and you can use it there. So as I said, it's useful in selected situations wherein there's a potential for equivalent onco-resections. It can give you shorter hospital stay, it can give you improved immunology, it can give you improved nutrition, you can get your adjuvant treatment in earlier, and these can be aids. These can be aids because ultimately cure depends on not only on the surgery but on being able to get adjuvant treatment in a reasonable length of time. There is some literature available only from expert centers. So it's not really literature available from every center, but the expert centers have started to now show that this works. So this was one of the earlier papers. This came out in 2010, and this basically showed us that in terms of morbidity, this has made a difference. There are some other papers. This is from Piero Nicolai group. He's by far the leading exponent of this kind of thing. And he has divided this into exclusive endoscopic and cranioendoscopic. So exclusive endoscopic is the first case I showed you, and cranioendoscopic is the second case I showed you. And so he says that we started out with the exclusive endoscopic of the smaller tumors, and now we do the bigger tumors. But you start looking at the results which are there at the bottom, and you start to see that for these selected patients, they're doing very well. Selected patients, remember selected patients are doing fairly well in terms of disease-specific survival. This is from the UK. Again, tumors, you have to look at the histology. You'll see that hardly any squamous cell cancers or factory neuroblastoma, good tumor to get involved with because the adjuvant treatment works, and it's generally sort of only attached to the roof of the nose, so there's not too much mucosal involvement. Adenocancers can be low grade. So careful. This is the last paper which has come out only a couple of months ago. This comes from the Pittsburgh group mainly and their associates, and the first thing they tell you is that whether you do open or whether you do endoscopic, if you get good margins, you get great results, and if you don't, then you get poor results or not so good results. That is obvious, but the fact is that even with endoscopy you can do well. Here they have compared CADISH B and CADISH C or factory neuroblastoma, and they have started to show that endoscopic has started to do better than external. There must be case selection because there are many kinds of CADISH B and many kinds of CADISH C, and obviously this is a retrospective look. But nevertheless, the results are coming out to say that this can be oncologically appropriate. It's still early days, we should be careful, but it does seem that in terms of morbidity, this is a good way to get involved sometimes, and in terms of control, this is a good way to get involved sometimes. But again, case selection is the key. So thank you. So, well, careful case selection, just looking at the same thing. These are the case selection issues, and these are surgical execution issues, which I would say are take-home messages for us. Thanks again. Right.